Hello, my name is Yejun Hong. I'm a medical student in the University of Calgary, and our team is here to explain infective endocarditis as a link between ophthalmology and cardiology. The eyes as end organs and the heart are intricately connected. First of all, an internal carotid artery connects the two organs, and certain clots or abnormalities from the heart, therefore, can directly affect the anatomy of the eye. One important proof of that is infective endocarditis, where clumps of bacteria from the heart can travel all the way up into the eyes. So, infective endocarditis is the infection of endocardial surface of the heart valve or intracardiac device. And the top organisms that are responsible for this disease is Staphylococcus aureus 1/3 of the time, very dense group of Streptococcus in 17%, coagulus negative staphylococci, and Hasek group, which are gram-negative bacilli including Haemophilus species. For H, Aggregatibacter actinomycetin comitans. For A, Cardiobacterium hominis for C, Acanella cordans for E, and Kingella kingae for K. Before we move on, it will be prudent to know the anatomy of the retina. The fovea and the macula have the highest concentration of cones, and the light that converges here is what makes up our central vision. Optic disc is on the nasal part of the retina, and this is the point of exit for all the ganglion cell axons from the retina. Ironically, the lights converge here cannot be interpreted in the brain, and thus forms a blind spot. Vessels of the retina, both the veins and the arteries, branch out from the optic disc and can be seen with the fundoscopy exam. There are a lot of different layers within the retina itself. Retinal nerve fiber layer contains the unmyelinated axons of the retinal ganglion cells. There are a lot of different nerve cells, such as ganglion, bipolar and horizontal cells, as interneurons, and sensory cells, known as photoreceptors. The plexiform layers contain the synapses between these cells and more, and retinal pigment epithelium is between the choroid and the photoreceptors and works to nourish the photoreceptors. Here is a lateral view of the eye in the context of the internal carotid artery, as well as the ophthalmic and the central retinal arteries. And also a closer look of the lateral view of the eyes that shows the long and short ciliary arteries, the circle of Zinn, the vortex veins, and Schlemm's canal. The pathophysiology of infective endocarditis starts with the increased vulnerability of the valves in the heart to bacterial adherence. This is done by any trauma to the valve that alters the endothelial cells, and also disruption of the surface, which physically roughens the surface and also exposes the factors present beneath the surface layer for the deposition of platelet and fibrin. Once these abnormal pathology of the valve is formed and some of the coagulation factors are laid down, the bacteria in the circulation would then be able to adhere better to the valves. There are also help from the virulent factors released by these bacteria. And once these bacteria has seeded and found the surface to grow, a whole colony can propagate on the valve surface. Then the emboli can be broken off from the force of the blood flow because there are such a sheer number of bacteria. This is called septic emboli, and this emboli made up of these pathogens can travel all the way up to the retinal arteries. In the retinal vasculature, it can form Ross spots, which is observable through the fundus exam, and also BRAO. Being older than 60, being male, and poor dentition and using IV drug use can be risk factors to infective endocarditis. Medically, having implanted devices like prosthetic valves and pacemakers, as well as having indwelling catheters, can make an individual vulnerable to infective endocarditis, and structurally, mitral valve prolapse and having rheumatic heart diseases raises the risks as well. The criteria for determining and diagnosing infective endocarditis is by modified Duke's criteria. There are major criteria and the minor criteria. And depending on the number of them for which an individual qualifies, then the diagnosis can be definite, possible, or rejected. The major criteria is made up of 1. Supportive laboratory evidence. So seeing on 2 separate blood cultures the virulence strep, Hayseck group, and Streptococcus and Staphylococcus. And second criteria in major category is the evidence of endocardial involvement. There will be a specific finding on the echocardiogram, including oscillating intracardiac mass on echo, on the valve or supporting structures, the mass being present in jets of the blood, and also having no other explanation of this mass. Finding out a new valvular regurgitation, which would be heard in the diastolic portion of the cardiac cycle, can also give strength to this criteria, and this is as opposed to the change in pre-existing murmur. There are 5 minor criteria, first being predisposing heart condition or IV drug use, fever spiking greater than 38 degrees Celsius, and observing vascular phenomena like Janeway lesions, arterial emboli, septic pulmonary infarct, and conjunctival hemorrhage and intracranial hemorrhage. The fourth is the immunologic criteria, including glomerulonephritis, ocular nodes, and Ross spots. Positive blood culture is the content from major criteria, but if it does not meet it, for example, having only 1 positive blood cultures as opposed to 2, or finding organisms that does not cause endocarditis, it will be included in the minor criteria. Signs and symptoms of infective endocarditis include B symptoms such as fevers, chills, night sweats, and weight loss. These are observed in infections, inflammations, and cancer. Congestive heart failure or new murmurs, as we've discussed in the major criteria, can be observed as well. Splinter hemorrhages and petechiae, as well as splenomegaly, can also be seen. Janeway lesions, ocular nodes, and Ross spots can be observed in the back of the eye as well. Here are some pictures to demonstrate some of the signs and symptoms. There's congestive heart anatomy, then splinter hemorrhages, splenomegaly, and when the spleen gets large enough, it starts to invade the right lower quadrant as well. And this is a Roth spot in the bottom right picture. Complications can arise in many different ways in infective endocarditis. In the hospital, heart failure or AV block, where signals from the atria does not get passed to the ventricles for efficient pumping of blood are possible. In terms of the nervous system, stroke and brain abscesses can form as the smaller microemboli made up of bacteria travels up into the brain. Septic emboli can affect the kidneys and the spleen. The sheer degree of infection can go to the bone and cause vertebral osteomyelitis, septic arthritis, and also cause abscess in the psoas muscle and the spleen. Systemically, the hyperactive immune reaction can cause glomerulonephritis in the glomerulus of the nephrons within the kidneys. Chronically, because the pathogens have attacked the valves of the heart, valve can be destroyed, and that could lead to heart failure due to inadequate compartmentalization of blood during pumping. There is also often an indication for valve replacement. In long term, kidneys can fail and require dialysis, and stroke can occur as well in the long term. Differential diagnosis can include other causes of fever in cases of infective endocarditis-like presentation, and this could either be pulmonary embolism, which is an emergency, DVT or deep vein thrombosis, and pulmonary embolism can also arise from DVT. So the embolism from the thrombosis in the leg can travel up to the lungs, and lymphoma, which can also cause Roth spots in the retina. Atrial myxoma, which is a unique cancer within the heart, antiphospholipid syndrome, Lyme disease, and polymyalgia rheumatica, which is autoimmune syndrome. It can also be alternative diagnoses that can be explored. Upon seeing the patient, take a detailed history of presenting illness, what has happened, what symptoms have they been experiencing, and if things are getting worse or better. And pay attention to the history of fever and heart murmur if they hear anything from their heart. Inspect the skin thoroughly for any new lesions or discoloration, thickening, atrophy. In terms of the eyes, perform visual acuity, pupils, and pressure as basics before you move on to slit lamp exam. Check visual fields and do the fundus exam. Look at the retina thoroughly in all directions and check for plaques and Roth spots. Precordial exam of the heart for any murmurs would be important as well in certain settings. Investigations would be looking for the septic emboli within the heart. This is done by echo, and transthoracic echocardiogram has specificity of more than 90%, but sensitivity of between 60 to 80%. Especially smaller vegetations, less than 2 to 3 millimeters, may be missed on the transthoracic echo. That's why transesophageal echo is there for backup. The specificity and the sensitivity in this modality are both greater than 90%. So we choose this if the complications are suspected and prosthetic valve endocarditis is suspected. Staphylococcus aureus bacteremia can be dangerous, and instances of intracardiac devices. And lastly, if the TTE images are not ideal and you would like a better confirmation, then we can turn to TEEs. Take 3 instances of blood cultures to be sure of the pathogens you're dealing with. Treatment for infective endocarditis include antibiotics after the blood cultures are taken. These are usually initiated before the results come back with broad spectrum to deal with the pathogens as soon as possible. And the specific agents according to the circumstances of the patient is shown on the table on the right. After blood cultures come back, the treatment can become more targeted. And mainly, if the valve is natural, or organic for that matter, we turn to vancomycin and ciftriaxone. If it's prosthetic, we go to vancomycin and gentamicin plus rifampin. Surgery is also a treatment option for severe presentations. For valve dysfunction causing heart failure, fungal infective endocarditis, when fungus invades in this level and scale, it indicates that the immune system is too weak to fight the fungus off. This is a very rare case. And resistant organisms to antibiotic agents. These 3 scenarios all make surgery more likely to be the main treatment for infective endocarditis. Prophylactic antibiotics for patients at risk can be shown on the picture on the right. The 5-year survival rate after discharge of infective endocarditis patients is 85%, and the cause of death of the 15% is heart failure, and the mortality is highest during the initial phase of recovery. So here is again the link slide between ophthalmology and cardiology. And hopefully this concept is reinforced with infective endocarditis. Here's a summary chart of everything we talked about. And this is the reference from which we drew all the information required for this presentation. Thank you for watching this video.